So professional education this morning, welcome Dr. Ann Kenny. We're so excited to have you. She'll be presenting today on serving and supporting clients to live well with cognitive loss. Dr. Ann Kenny, MD, is a geriatric and palliative care physician with a clinical practice in Connecticut. She is a professor emerita at the University of Connecticut Health, where she practiced medicine, conducted clinical research, and taught for over 30 years. She is currently the founder of Together in Dementia, where she coaches, consults, and speaks on topics involving dementia, aging, caregiving, and end-of-life issues. She is the author of Making Tough Decisions About End-of-Life Care and Dementia, Johns Hopkins University Press, and has a book co-written with Teresa Webb, Your True North, a guided journey for those living with cognitive loss or dementia about legacy, love, and wishes for the end of life well lived, published in just this January of 2024. We're excited to have you, Dr. Kenny. Thank you so much for taking the time, and you just go ahead and roll with that. We can't wait to hear what you have to say.
Thank you. Thank you for letting me present with you today. It's such an honor. I love the Learn community. I'm a little intimidated by the Learn community, and I wish this were more of a two-way so that I could learn from you rather than presenting to you. But thank you for that really nice introduction, Karen. And it reminds me to shorten the names of any books I have in the future so that it's not such a mouthful. I guess Dara is going to drive for me. Thank you, Dara. I'll go to my first slide. What we're going to do today is go over a few key points, and I hope I hit these objectives. And if I don't, I also hope I have enough time at the end that you get to answer any of your questions you have can be answered. I'll do the next slide. So I want to start by saying that in the world of dementia, things are changing. Up to now, most of the time, dementia is diagnosed at kind of the moderate stages of dementia, maybe at some early stages, but not so often. But what this slide is showing us, and I'll go into the slide more as we go on, but that we are about to have a point in time where we will be able to be diagnosed with dementia much earlier, way before you have any clinical symptoms. And the reason for that, and most people would say, well, why would I want to be diagnosed with dementia? Because it's much like death, and we don't want to think about that. And it's because we are starting to know that there are so many things we can do. There's some new medications that have some hope of modulating the disease so that we can take dementia from kind of a long but terminal disease to more of a chronic disease, and shift all the symptoms to the left, and so that we're not symptomatic very long, if at all. That the science is changing dramatically so that there hopefully will be new and better medications, and probably it will become a chronic disease with a chronic medication to kind of hold things at bay in the not that distant future. There's blood tests that will help us look at some of these markers that are on the slide that will allow us to know earlier, because if we're going to do things that are preventive, we have to do it in the it seems from the studies that have been done so far, we have to do it in the preclinical phases. And so we know that lifestyle changes, exercise, and a Mediterranean diet or something similar have been helpful to people who have found out that they have dementia early, and has been able to move them from having being in the late stages to remaining in the early stages for years and years. And people living with dementia, with early stage dementia, are becoming a really strong voice for changing the public perception of the way dementia is. I'll do the next slide. On the slide before, there was the Clinical Dementia Rating Scale, the CDR. And one of the goals of this talk was to talk about how dementia presents early on, because we're going to focus this talk early on. And again, I feel like this crowd knows a lot of these things, so I'll try to be brief. But in that clinical dementia rating scale, early dementia is considered anywhere from 0 to 1 on that rating scale. The rating scale is made up of these 18 boxes. So it's memory, orientation, judgment, problem solving, community affairs, home and hobby, and personal care. And in the grayed out area at the top are where you have either a score of 0 or a score of 0.5. And the scale on that other slide, if you can stay 4 and under, you stay at a CDR of 0.5. And that's when people are doing very well in the disease. And so if you have dementia, and you say in memory, you're in the first box below the grayed out area, the darker gray, that would be a score of 1. If you then were pretty good at orientation and you were in the half grayed out, the lighter gray, exactly, that you would be 0.5. If you went on to judgment and you only had some slight impairment in judgment, that would be another 0.5. You could go down to community affairs, and maybe in the darker gray, be unable to function independently when you're out, but still most people would not even notice that anything's wrong with you. Going back up to hobbies, you could have life at home in the second light gray box, another 0.5, and then you're fine with your personal care. You would then have a score of about 3.5. You're doing really well, functioning very well, maybe needing a little bit of support for some memory issues, support that would just be some training, or when you're going out, you might need a little bit of support, living a really nice life. And if we can keep dementia at preclinical or that place, that you're doing very well. Once you get down into the darker gray boxes at the bottom, you are needing more support from family and friends and our community. And so that's what we're going to be talking about today. How can we as business leaders, how can we as family members support people living with dementia to have a good life, especially those people in the early stages? Okay, next slide. And I just wanted to highlight Teresa Webb as an example of living well with dementia. She is the co-author of the book that Karen introduced you to at the beginning. But Teresa it's unclear to me how long she's had dementia, but she tells me different times all the time. Again, that's that timing issue. She's a little bit off on that sometimes, but she's 69 years old right now and was diagnosed with dementia probably in her early 50s. So she's had dementia somewhere between 15 and 20 years. And in this quote, she'll tell you that at first she was devastated, which is the common reaction to most people. But she kind of shook herself out of it and thought, I do not want this disease to define me. I want to live with this disease. And so she's gone on to become a huge advocate for people with frontotemporal dementia. She's spoken before Congress. And recently, 20 years into her disease, has been a co-author of a book. And so this is what I think living a good life with dementia can be. And she's just one of the many, many examples. I think, we're in the hundreds at this point, hundreds to early thousands. And I think with these changes and the things that are coming, we'll be in the multiple thousands, so that hopefully a diagnosis of dementia will not be as devastating as it has been in the previous 20 years. So the next slide, I ask, what is a good life? And so when I was thinking, well, if I'm going to talk to people about what's a good life, so I looked some resources, and I'm sure we can debate on this for a long time if we want to. But this one psychologist has put forth that it's, material comfort. you have to have some of your basic needs met and well-being. So if if you're suffering from some mental illness or deep depression, probably not a good life at that point. But then the other things are things that we often don't imagine for people living with dementia, meaning engagement in meaningful activities, loving relationships with partners, families, and friends, and belonging to a community. But these are aspects of a good life, and these are the things that people living with dementia want. Um, so, what gets in the way? And I would go to the next slide for that. And it's usually stigma. And the stigma comes from the person living with dementia. It comes from each of us, whether we want to acknowledge that or not. And it comes from our culture. In the US, we value independence. We see ourselves as dependent or independent. It's kind of an either or. We don't often kind of go into the gray areas of you're something in between. Um, so how do we address that? We have to kind of move to this place of interdependence. Mary Pfeiffer, so the next slide, is a anthropologist, a psychologist, and author of Women Rowing North. And in her book, she speaks mostly of ageism, but I think we could do this, we could extrapolate that to um, people living with early dementia as well. But she says that she quotes a study from the Yale School of Public Health that 75% of young people denigrate older adults on Facebook. So it's a cultural thing that we put off. We don't see aging as independent. We do not see dementia as independent, and that's what we do. And she says there's no cultural script for the story of our complexity, our wisdom, and our joy. And that isn't true in every culture. There's a lot of cultures that would always see us as interdependent and suggest that we could reconceptualize the interactions between the young and the old, the cognitively intact with the cognitively challenged. As part of a circle of caring that begins with the oldest living relatives or some people with some impairment and flows on down through the youngest. And when we don't interact, we stereotype. And so the work of Pfeiffer reminds us to challenge our own ageism, our own and develop that interconnectedness across generations, across cognitive abilities. Um, and for those people living with dementia, they need to challenge that fear of going out and becoming vulnerable. And so if we can support people with cognitive, I say we as if I honestly think I'm going to be one of those people living with dementia. And so I'm starting to challenge myself to make sure that I don't remain isolated and that I value the aspects, the things I still can do, the things I still want to do, and not let my fear of being taken out of the pack for making a mistake. So we need to help and support people as they go through that. Um, and one of the ways that I try to support that moving into the interdependence is by trying to focus most of my talks around people's voices who are living with dementia. And so the next slide is a slide about friendship. And it is the work where they actually got voices of people living with dementia talking about what they would want from friendship. And then I want to extrapolate that into how we would use that in business. So these authors, using a positive social interaction model, said that asked people living with dementia what they value, what's important to them. And they've realized that personal well-being, providing emotional, psychological, and health benefits um, from this social positioning model help people understand that they needed a give and take in relationships to make those relationships wonderful, and that provided a balance and an equity. And so the five themes that come from this study that people living with dementia said were they want longevity, so they don't want people to abandon them. They they want to help one another as a normal part of friendship. They feel alive from the give and take of those friendships. So not just to be given, but to have it recognized within the relationship where there's benefit coming from them. And then they want to know that people are there for them, and they want some security in that friendship. And so in the next slide, I think my question, and I think the Learn community is perfect for kind of being the vanguards in this, is that what do we do in our, I guess the rest of the talk will be kind of like, what do we do in our businesses, in our places, in our homes to foster this friendship model that the people living with dementia have put forth to us. What can we do in our business to make them more open and affirming? How can we adjust and adapt to accommodate the disability of cognitive loss? And how can we advocate? And so I just put up a few slides of things that some people have done. There's Dementia Friendly America. You can go there and do become a dementia friend. You can find out some of the practices that they think are important for businesses. You could host potential. I mean, these are just, I'm just riffing on ideas. You could host a dementia cafe, much like the death cafes. Again, it's to increase awareness, have a safe community. It can just show that you are kind of a dementia approachable place. You can ask people living with dementia what would help to accommodate them within whatever your business structure is. Um, and I know that a lot of you are already doing this. So if you can help move that needle for other businesses or other interactions you're having, I think those are great places to start. And when people say to me, so when these kind of things come up, people say, but I don't know how to communicate. So the next slide is about one of the barriers would be the communication changes that come with aging and with cognitive loss. And we know that that the cognitive changes themselves can can cause trouble both with finding words or communicating out, but also in how well people are hearing. And not, I don't mean by understanding, how well people are understanding, or the speed at which they can process what's going on. That's the following the conversation. A lot of people with dementia tell me that they feel embarrassed because they can't keep up with the conversation. It's too complex or needs to be slowed down. There's um, uh, in some forms of dementia or in some aspects, there can be this lack of being able to express your emotions. So people feel that the person living with dementia is not as engaged with them. And then there's just things that complicate just communication as we age. The changes in hearing, potentially changes in vision, so you're not seeing some of the nonverbals. And then there's the social factors. There's that, what if they're confused? And people living with dementia often avoid that communicating because they're afraid of being, quote, found out. Um, and then I'll do the next slide. So again, in that, in in honor of the people living with dementia, these are recommendations for communication strategies come from a group of people living with dementia that we were working with on a research project. And they said these are the things that would help. But first, I mean, one of the first things they said is just keep it light. Don't worry about it so much. Keep it light and realize that most of what happens comes from intention and feeling. And so the quote at the bottom, who came from a patient's daughter who very eloquently said, "And maybe he won't remember what I said, but he'll remember how I made him feel." And that's often the goal, is to intend for that. I want to be here to be supportive. I want to be here to communicate with you. And so we will find a way forward. But what the people living with dementia have told me is to speak clearly, to keep the messages simple. And by simple, I don't mean not, I mean direct, not a lot of fluff. Um, uh, to focus on one idea at a time. We tend to multitask even in our speech sometimes. And when you're speaking with somebody with cognitive loss, you want to kind of stay focused on one thing at a time. Use nouns rather than pronouns. So if you're talking about something, I use an example of rather than put that over there, you would say, please place something on a chair. That put that over there is too vague. Avoid background noises and distractions. I often see people living with dementia in a hospital setting, and the TV's going, and bells are whistling and things. And I'll shut TVs off. I'll draw curtains. I'll try to put us in a cocoon so that our communication is improved. Um, uh, Use nonverbal as much as you can, so that you're reinforcing um, the message, uh, because different parts of the brain are affected for different people. Everybody has a unique brain. And then be patient, remain calm, and try not to be disrespectful or interrupt. My mom lived with dementia, and she's the one that taught me. I was all like, she had word finding difficulty early in her disease, and I would be jumping in all the time, and she would just give me this look that I know from my childhood, which meant, "Are you kidding me?" And so, but it took a long time for me to quit interrupting and quit. She just needed a little time. She just needed a little bit of time, and it would have been fine. But by me jumping in, I was constantly making her feel less than. And I finally learned to stop doing that. And I think it helped my clinical practice as well. And then just again, allow people time to respond. So those are some of the suggestions that people have to help communication. And so um, from knowing that stigma can hold us back, both the people living with dementia's own stigma on their dementia and the cultural piece. What do we do next? I think that depends a lot on our business. And and I know we're talking about people with early dementia and then people who are supporting those with dementia. But I think the focus today, in my mind, is more on those people with the early dementia, who I think we're going to be seeing more and more as the horizon changes in dementia care. Um, but the early in the disease, they need to feel hope and support is key. And I know hope is not a plan. I heard that, but they need to feel supported, and that there is something to kind of counter that dependence that we um, we put with dementia, and see that it's such that it's not black and white, that there's so much gray area. So interventions that can in research, it actually shows that interventions to cultivate hope improves quality of life and reduces symptoms of depression in people with uh, neurodegenerative disorders like dementia. They As Teresa mentioned, she had that period of psychological distress in that time right after the diagnosis. And it was somebody who asked her opinions about something and asked her to present in a presentation that pulled her out of that. And that's when she was like, I have things to give. This person values me and sees that I have something to give. And it was that she um, credits to her kind of turning her life around. And what we know is that in those studies where you can cultivate hope, um, people had about a 30% distress rate. That went down to about 5% compared to those who didn't feel their hope was cultivated. And their distress rate from the early days went from about 30% to nearly 50%. So it really does matter how people are supported early in after their diagnosis. So I guess the point is they need to hear stories of living well, of adapting, that things can be normal, and kind of see the positive side. If it's legal things, they need to what I've been told by people living with dementia is, yes, I know I need to get my affairs in order, but not just yet. I need a little bit of time, or I need you to frame it so that I see it not as we're talking about my death so much, but as me, like frame it so that it's for me to live well now. And again, I know I'm speaking to the choir here, but that's the kind of hope they're looking for. Um, Again, I wish this was much more interactive and not me just spewing, opinions, but, that's what I mean, and for me, again, I'm a geriatrician, but I'm also a palliative care and end of life specialist. I think of this early phase as a time when it opens doors to active participation in determining future care and treatment. Um, and so I want people to, after they've gone through that initial period, to start contemplating what it is, how they want to live in this hopefully many, many, many years of living well. Um, but I want them to be those active participants in it. And so again, I look to the literature to help me hear what people living with dementia have said, besides those in my clinical practice, which, I think is very important, but it's nice to have it backed up in some ways. So the next slide talks from a study. Um, oh, we'll just skip this one. I think we've talked through it. But the next slide is from a study by Sellers and colleagues where they looked at 2,600 papers to cull out themes on how people looked kind of at the end of life. And in those 2,600 papers, they found the voices of 390 people living with dementia. That's it. I mean, that's how little there is in the literature. And 1,800 caregivers. This is over many, many age groups, many, many countries. I mean, it's basically they culled the entire literature for what people said, and they found 5 themes, which are on the slide. And I'm going to go through them one by one, but I'm gonna go through the themes one by one, and then I'm just gonna shift to, h how then do we take that theme and employ it in our business or in our interactions? So the first slide is the next slide is theme 1, which is avoiding dehumanizing treatment, and that's one of the themes people said is that they they do not want they want the much like what the death doulas would find out from them is they want a social, sensory, and spiritual engagement, much like normal. Um, they think institutions can be too focused on institutional policy rather than patient-centered or person-centered approaches. And they wanted those who filled out an advanced care plan wanted more of a natural death, accepting that dementia at some point can be terminal after living a period of a life well lived. And those who did not fill out the advanced care plan didn't because they struggled to understand dementia's progression and the signs and symptoms that would tell them that they'd entered the late stages. And so in the next slide, I just I guess I ask you to think about how do you imagine what dehumanizing is to you so that you can kind of be in the headspace of somebody who's living with cognitive loss and thinking about these things so that you've kind of raised your consciousness to what they might want to talk about because as as we know we don't talk about death. So I'm so happy to hear that you have these let's talk about death events in your community. I would highly recommend you go to them, and I think this helps help you figure out like what is dehumanizing. And people don't talk about death. So besides some of these death events, you could host something called a death over dinner. That's an idea maybe to help you start talking about death with in many of my jobs people would say, but Anne, I worked in think tanks and long-term care facilities and clinical places. And these are often healthcare providers. And they were like, I don't know how to talk about death. I don't know how to think about death. And so I would host death over dinners, which are a brainchild of Michael Hebb, who is an entrepreneur and restaurateur, who thought maybe over a little bit of food and drink, we can have these conversations. And he has a website that has several curated uh, readings and videos and suggestions on how to host a dinner like this. The next slide is the second theme is confronting emotional difficult conversations. One thing I didn't realize is people thought that if you talk about death, I talk about death all the time. So this, in my family, we always have. My grandfather was owned a funeral home, so I didn't realize that people thought that talking about death might cause death. Many people think that thinking about cognitive decline is too frightening, and that those people living with dementia felt that if they did an advanced care planning, that ticking those boxes locked them in and really minimized what they want. Not, it became, I clicked a box and so nobody talks to me about it anymore. And from that theme, I'll go to the next slide. Consider how we can address these conversations. Death over dinner is one. Those conversations might be tools that help, but again, in your business, how can you, people are not going to want to bring it up. And um, so if you can find ways to ask people how they want to live, and they'll get the idea that we're talking about how can we support you around the changes that are happening. That's, people want someone to ask them. And I think that's the point of this one. And then the next theme, trying to be cognizant of time, is navigating those existential tensions. And a- again, it becomes that theme of these are heady waters that we're walking in, and people aren't used to having these conversations in the United States anyway. This one really highlights to me that caregivers are very worried that they're going to be responsible for a death, maybe a premature death because of a decision they made, and they don't want to make these decisions. And what we do know is that if we can help the person living with dementia articulate their wants and desires, much like the 3 questions, let's not stop at 3, and communicate them to other people, it will help those that end up having to make those decisions for the person living with cognitive loss. So to facilitate these conversations early is important. Maybe not, I mean, I think it's important for the person living with dementia, but for the person left behind, the person who has to make the decisions, it's priceless. And how can we so I guess the next slide is how can we facilitate this? How can, and for me and my mom, I knew that, I mean, I knew what was coming as a clinician, but it was happening with my mom. And so I used therapy to kind of grapple with some of these existential things. And I asked my mom to use a therapist, somebody away from me, to grapple with some of the things so that she could so that she could get past her, I don't know if I want to burden my daughter with some of my deepest, darkest fears. So she talked to a therapist about it, and the therapist coached her into this. And there's others that can do that. I mean, if you're in a strong faith-based community, the spiritual leader can be helpful. If you're, writing and journaling, but many of the businesses and learn, this is your day to day, and I know that. But so again, I wish this was more back and forth, because I would love to hear and learn from you. But talk to each other at these, please. I won't be there this time. I have one networking event. At your networking events, please share some of these things. in my honor, or like for me to keep these conversations going. Okay, I'll go with the next slide. The theme for it was defining their personal autonomy. There's people are unsure what's coming, so they don't know what their preferences are if they don't know what their choices are. They People with cognitive loss did say, I'm afraid that the person that I have designated as my care provider won't advocate for me. And I hope that's not true, but at the same time, I also know that people tend not to tell each other. As Karen was saying, like, you have to tell people what you want, or they can't advocate for you. And then, how do people wrap their heads about just justifying treatments around health deterioration? And treatment, I when I read things like this, I think people are talking about medical interventions, and they're not. Like, it's the full holistic picture of care. What is care? And so again, there's a lot of anxiety about this. And so what can we do? How can we assist our clients, our family, partners in learning to ask for what they want and need, to the healthcare system, to their family members, to be their advocates. So again, that's expand your network, get as many ideas as you can from as many people as you can. The Conversation Project is one way to learn how to have some of these conversations. So it's conversationproject.org, has some great tips. But this stuff is important. And then the next slide is that there's a lack of confidence in the healthcare setting. Believe it or not, who knew? Um, that that people living with dementia and their care providers are distrusting of um, what their doctors know, what their doctors are willing to tell them. Um, and they feel like they're making uninformed choices, and they're deprived of, and this is true, they're deprived of access to hospice care and support at the end of life. Um, I just kind of saw in the chat that there might be some questions, so maybe I'll get to that in just a minute. But these are the kinds of things that I try to address, because when my mom was living with and then shifted to dying from dementia, I I was shocked that a lot of my colleagues didn't see that shift as I did. Um, and I and and some of the healthcare providers, or some of the people at some of the places that she lived, said to things to me like, "Why are you starting hospice? You're giving up on her." And I was like, "Absolutely not. I'm adding a layer of support." So this is still very, I mean, my mom, I guess, died 10 years ago, but still surprisingly pervasive in our society. At the time, only about 5% of people in hospice had dementia. It's up to about 20% now, and hopefully rising. Um, but people, they're right to worry that this is a problem. And so the next slide would be, um, I would be happy to answer some questions. And I can't believe I only have about 4 minutes, and I think there are some questions in the chat, but if you'd rather,
There are.
okay. If somebody wants to read them to me or tell me.
I can
Oh,
read them too here.
Okay.
With early diagnosis blood tests, how is it going to affect people with insurance? Will people be labeled early on?
Um, that's a good question, and we don't know the answer to that, but I know that right now there are people who are getting uh, genetic testing and not letting their insurance company know, because it may affect insurance issues. I think it would definitely affect life insurance. Healthcare insurance should be. I'm we are at a crazy time in history. I'm not sure what would happen, but I think for you to get into clinical trials, or to get access to treatments that may modulate. I don't know if it's as important right now with the disease modifying treatments that are available. I was just at a talk on Monday night that had two neurologists at it, and they said that um, they have seen people with early cognitive changes or with blood tests and spinal fluid tests that suggest that without many clinical symptoms at all, who have been able to receive some of the newer infusional drugs that take amyloid plaques, and that they've seen that their plaques are gone, and that they've actually reversed some of the early cognitive changes they've seen. That's an N of a couple. We need more data on this. So honestly, I'm not sure I would get tested just yet until there's going to be some new medications, hopefully, that are focused on tau, so the amyloid is between the cells and tau is the tangles are in your brain, in your brain cells. So I think when there's more tau medications, I think we'll see some different changes, and health insurance might not be as negative. The
I think
impact.
I think that what we're seeing in health insurance, in employment, and all of these things is part to the stigma. And, this idea of living well with dementia is a new idea, because the picture people have of dementia is the end stage of dementia. And so this is really a change we all have to pioneer and help articulate, is this capacity for those very early years to be living well with dementia. You can still live very well. And I've had the opportunity to hear Anne speak on many occasions. And one of the favorite things she says is, there is a long period of time where you live well with dementia, and you can live well with dementia. And then there is a time when you start to die from dementia. And what we know today and what we focus on today is dying from dementia. So.
Right. Or the just right before you make that shift.
Yeah.
And that is not the part where you're living well. You're starting to transition from living well to dying. And that is, that's what makes money for big organizations. That's what the media focuses on. And that's that cultural change we need to see.
And I think the idea of years and years of living with dementia is a new concept.
Yeah.
For many.
Right. And I think the way we're going to get to the point where we can find a cure for dementia is these early blood tests and getting people to do lifestyle. I think lifestyle changes will be a huge part of it, and then maybe some medications, or teasing out. There's probably 200 different diagnoses. We think about 5 or 6 things like Alzheimer's, vascular dementia, frontotemporal, Lewy body, and Parkinson's. But there's so many others, and we'll figure out the right treatment for different things the more we can get there. But we have to start the process before it kills those brain cells.